Hello and welcome. In this video, we're tackling one of the most time-critical emergencies in medicine, acute chest pain. Before we dive into our main topic, it's essential to build a differential diagnosis for any patient presenting with acute chest pain. We can categorize the causes by system. Cardiovascular. Think of acute coronary syndrome, acute aortic dissection, and acute pericarditis. Respiratory. Key life threats here are a pulmonary embolism and tension pneumothorax. Gastrointestinal. Conditions like GERD, esophageal spasm, and esophagitis can mimic cardiac pain. And finally, musculoskeletal causes like muscle spasm or chest wall trauma. Today, our focus is on the most common life-threatening cause, acute coronary syndrome, or ACS. So what is acute coronary syndrome? ACS is an umbrella term for a spectrum of conditions caused by a sudden reduction in blood flow to the heart. The most common underlying pathology is the rupture of an atherosclerotic plaque in a coronary artery, leading to thrombus formation. This spectrum includes STEMI, or ST elevation myocardial infarction, which signifies a total occlusion of the artery, NSTEMI, or non-ST elevation myocardial infarction, which indicates a subtotal occlusion, and unstable angina, which also involves a subtotal occlusion but without enough damage to cause a rise in cardiac enzymes. Clinical presentation and risk factors. How does a patient with ACS present? Look for these key clinical features. First, the classic chest pain. This is often a central or left-sided chest pain described as a tightness, heaviness, or constriction. Crucially, it can radiate to the neck, jaw, or the left arm. Breathlessness is also common, often due to pulmonary congestion. Syncope or fainting can occur, usually from a dangerous arrhythmia or significant hypotension. And vomiting, which is often triggered by intense vagal stimulation. On examination, the patient may show signs of distress such as sweating, diaphoresis, pallor, looking pale, and an abnormal heart rate, either tachycardia or bradycardia. A critical note: silent MI is a real phenomenon. Be highly suspicious in patients with diabetes mellitus or in the elderly who may present with atypical symptoms like confusion, weakness, or just feeling unwell. And who is at risk? We divide risk factors into modifiable, hypertension, diabetes mellitus, obesity, and smoking; non-modifiable, older age, male gender, and a strong family history of premature coronary artery disease. The diagnostic approach. Reaching a diagnosis for ACS rests on 3 pillars. 1. History. It starts with the patient's story. For example, a 45-year-old male who is a smoker presents to the emergency department with acute central chest pain. 2. ECG. An ECG must be performed within 10 minutes of the patient's arrival. If the ECG shows clear ST segment elevation, a diagnosis of STEMI is made, and you do not need to wait for cardiac enzymes to proceed with treatment. 3. Cardiac enzymes. The key biomarker is troponin. It begins to rise 4 to 6 hours after the initial insult and can remain elevated for up to 10 days. Decoding the ECG in ACS. Let's get specific about the ECG findings. For a STEMI, you're looking for one of 2 things: new ST segment elevation of 1 mm or more in at least 2 contiguous limb leads, or 2 mm or more in 2 contiguous chest leads, V1, V6, or a new left bundle branch block, LBBB, in the context of a convincing clinical history is considered a STEMI equivalent. There's also a classic evolution of ECG changes in STEMI. The earliest sign can be a tall positive hyperacute T wave. This is followed by the characteristic ST segment elevation. Over hours to days, you may see the development of a Q wave. And finally, T wave will invert. Now for an NSTEMI, the ECG findings are different. You are looking for ST segment depression of at least 0.5 mm in 2 contiguous leads, or T wave inversion in those leads. Note: pathological Q waves typically do not develop after an NSTEMI. We can also use the ECG to localize the infarction. Inferior MI, ST elevation in leads 2, 3, and AVF. This territory is supplied by the right coronary artery in 80% of people. Anterior MI, ST elevation in leads V1 to V4. This is the territory of the left anterior descending artery, 80. Lateral MI, ST elevation in leads I, AVL, V5, and V6. This is supplied by the left circumflex artery, LCX. Posterior MI, this one is tricky. You'll see reciprocal changes, ST depression and a tall R wave in the anterior leads, V1 to V4. To confirm, you must place posterior leads, where you will see ST elevation in V7, V8, and V9. The posterior wall is supplied by the LCX or the RCA. Acute management of ACS. Once ACS is suspected, you must act fast. Here's the initial clinical approach. First, ABCs. Assess airway, breathing, and circulation. If SpO2 is less than 92%, provide supplemental oxygen. Secure IV access immediately. ECG within 10 minutes. As we said, if it shows STEMI, do not wait for enzymes. Next, initial medical therapy. Analgesia. Potent analgesia is crucial. Use narcotics like morphine. Antiemetics to manage nausea from the pain or morphine. Dual antiplatelet therapy, DAT. Give a loading dose. This is 300 mg of uncoated aspirin plus a P2Y12 inhibitor, typically 180 mg of ticagrelor. Use clopidogrel, 300 mg if ticagrelor is unavailable or the patient has a high bleeding risk. High-dose statin. Give atorvastatin 80 mg or rosuvastatin 40 mg immediately, regardless of their baseline cholesterol. Nitrates. Give sublingual GTN, glycerol trinitrate, but be careful. GTN is contraindicated in right ventricular infarction as it can cause profound hypotension. Also avoid if the patient has used a phosphodiesterase 5 inhibitor like sildenafil recently. Beta blockers. Drugs like metoprolol or bisoprolol can be given. However, do not give beta blockers if the patient has hypotension, bradycardia, a high-degree heart block, or signs of acute heart failure. Anticoagulation. Administer an anticoagulant like fondaparinux or enoxaparin, LMWH. Definitive treatment, reperfusion for STEMI. For a STEMI, the definitive treatment is reperfusion, restoring blood flow. There are two ways to do this. 1. Mechanical percutaneous coronary intervention, PCI, also known as angioplasty and stenting. 2. Pharmacological, fibrinolytic therapy, or clot-busting drugs. A critical question arises: which one to choose and when? The decision depends on time and logistics. If the symptom onset was within 12 hours, both PCI and thrombolysis are options. However, PCI is superior. If a patient can be transferred to a hospital with a cath lab for PCI within 120 minutes of first medical contact, PCI is the preferred strategy. If that transfer time is longer than 120 minutes, you should not delay reperfusion. Give fibrinolytic therapy immediately, provided there are no contraindications. Between 12 and 24 hours from symptom onset, PCI may still be considered, but thrombolysis is no longer indicated. After 24 hours, if the patient is stable and asymptomatic, emergency reperfusion is generally not performed. After reperfusion, how do you know it worked? Look for 3 signs of success. 1. Resolution of chest pain. 2. Reduction of the ST elevation height by at least 50% on the ECG. 3. The appearance of a reperfusion arrhythmia, most commonly an accelerated idioventricular rhythm. Management of NSTEMI and unstable angina. Now, for NSTEMI and unstable angina, the strategy is different. Crucially, there is no role for fibrinolytic therapy. Most patients are managed with the initial medical therapy we discussed and then risk stratified to determine the timing of angiography PCI. However, you must rush an NSTEMI patient to emergency PCI if they have any high-risk features, such as hemodynamic instability or cardiogenic shock, persisting refractory chest pain, signs of acute heart failure, life-threatening arrhythmias like recurrent VT, or specific dynamic ECG changes like ST elevation in lead AVR with widespread ST depression, which suggests left main stem disease. For all other NSTEMI patients, we use a risk score, like the GRACE score, to guide timing. A high-risk score indicates that PCI should be done within 24 hours. A lower risk score means PCI can be safely performed within 72 hours. Discharge and long-term management. After the acute event, management continues for life. On discharge, refer the patient to cardiac rehabilitation, counsel on smoking cessation, control blood pressure, target 130/80 mHg, control diabetes, target HbA1c 7%, control lipids with a target LDL cholesterol of less than 55 mg per deciliter. The long-term medication regimen, often called secondary prevention, includes aspirin for life, a second antiplatelet like ticagrelor or clopidogrel for at least 12 months, this is DAPT, beta blockers usually for at least 12 months and often for life, ACE inhibitors or ARBs, especially if they have heart failure, LV dysfunction, hypertension, or diabetes, often continued for life, and high-intensity statin for life. Complications of MI by timeline. Finally, It's vital to be aware of the potential complications following an MI, which are often tied to a specific timeline. In the first 24 hours, the biggest risk is a lethal arrhythmia like ventricular fibrillation and acute heart failure. At 1 to 3 days, fibrinous pericarditis can occur, causing a different type of chest pain. Between 1 day and 2 weeks, we worry about mechanical complications from the necrotic heart muscle, ventricular free wall rupture leading to cardiac tamponade, papillary muscle rupture causing acute severe mitral regurgitation, interventricular septum rupture, creating a VSD with a loud pansystolic murmur, and from 2 weeks to months later, Dressler's syndrome, an autoimmune pericarditis causing fever and pleuritic chest pain. The ECG shows widespread saddle-shaped ST elevation. It's treated with NSAIDs. And finally, the long-term sequelae of true ventricular aneurysm and chronic heart failure.